So we'll just get started now as some of our residents are still going to continue to join us. But again, thank you all for coming out tonight. I'm Kaya. I'm one of the PGY3 residents at Rush University Medical Center. Again, we're super excited to meet some of you guys, and hopefully we can get some of your questions answered. Tonight we'll be talking about why RushEM. And so I know a lot of you have already submitted some questions, so we'll try to answer those as we talk about why we decided to come to Rush and why we love this program. Some of our residents are already on this call, and then we also have some of our newer faculty joining just to kind of give you guys their perspective of why they decided to choose Rush as where they will be practicing their career. So again, I'm Kaya. I'm going to pass it off to one of my co-residents, Lauren Werfs. She is also one of our chiefs who's joining us tonight. So go ahead, Lauren.
There we go. Hey, I'm Lauren. I'm also obviously a PGY3. Super excited to see all you guys. Usually public speaking, I generally take beta blockers, but in this instance, I might pass out obviously because I'm home alone. So this is great though. Zoom doesn't allow that, so that's good. But I'm really excited to see all of you guys, and obviously we'll answer any questions you can. And as always, like I'm pretty sure our emails are online, or if not, we can try to share them with you after this if you think of any questions that you didn't get answered or they popped up later on. I know that I always had a lot of questions afterwards, and I was always like, crap, I should have asked that, but I didn't. So always feel free to reach out, and I'm sure any of us are more than happy to answer those questions for you.
We have one of our newest faculty who's also one of our alumni, Dr. Corey Goldstein, is on with us tonight. Corey, if you just want to go ahead and introduce yourself.
Thanks. Yeah, Corey Goldstein. I just finished residency training a couple months ago, and I am almost 2 months into being an attending at Rush, which I'm thrilled about. I love it so far, and I think I'll continue to love it. And I'm happy to answer any questions today or discuss any of my experiences or anytime otherwise as well.
Awesome. Thank you, Corey. All right. So I'm just going to go ahead and start, right? I think one of the most common questions that was submitted was, why did we choose to come to RushEM? What makes this program stand out? And what has evolved about this program? And I guess I'll just start out. So, you know, I'm a third year now, so I applied for EM residency in 2017, and Rush had just started. Their program was just recently at that time accredited. They had just started their first class of residents, and I know a lot of hesitation goes into starting out at a new program. For me, though, I was blown away by what they were doing at this program and what the opportunities existed. For me, I really wanted to be a part of a residency program that I could help build and that could truly be resident run. And I think over the past 3 years now, going into our 4th year, and now as we're looking for our 5th class to join us, we've really seen how much this program evolves based on the residents' feedback and how adaptive our program administration is, the entire emergency department is, to what we need as residents and what we think would be the best for our practice style for our educational needs. So for me, that was like an automatic draw to coming to a newer program, not just Rush. And other things that were important to me was that I'm originally from Chicago and I wanted to come back home. So Rush was an ideal choice just because it's close to home for me. Some of the other things I really liked about this program at the time was the program administration. Our program director, as well as our APDs, were super receptive to all of the ideas that we had, even as an applicant, just talking about, you know, what potential they had for change and what involvement the residents could have to build this program, which I thought was awesome. As the program has gone on and I've gone from my intern year to senior year, I've really seen this program grow and change for the better. And it all goes down to our program administration being very receptive really invested in the program. We have a very open door policy with our program director and APDs, and I think that's a really unique feature of our program, which just makes it so much easier to be a resident.
So I guess I can go next. So obviously one of the biggest things that made me kind of choose Rush was the people. So with like the interview trail and everything, you just get to talk to a whole bunch of people. And obviously your guys' experience is going to be different than ours because of COVID, but you're still going to talk to people kind of in the same format. You're all going to be Zoom with everybody. So you can probably get a sense then of how you actually talk to people and if they make you feel comfortable. And honestly, the people at Rush and during the interview process, um, everyone was just so nice at Rush, and I just felt immediately like welcomed and at home when I was there. And Corey was the one that led me on my tour, and Corey was like amazing. And I told him that afterwards, and I was like, "You gave me my tour, and it was great." And he was like, "What? I did." So nothing against Corey. You didn't really remember me, but that's okay. But no, it was like phenomenal. Like everybody the night before were so nice, and it was just, and even then, like I can just say, like now being a third year, like the people in my class, I feel like they are my family, and I can go to any of them. There's really no issues with our class at all, and I can say the same for like the second years. They're like super close knit. We talk to them all the time, and the interns are great too, and they're like some of the nicest people. I really just think that the people are just phenomenal. And same with our staff. One thing that I liked about Rush is we started off as a new program, and when that happened, the attendings that came on board that they actually ended up hiring wanted to get into working with residents. And so it wasn't like they had been here and they were like, well, we don't really want to work with residents. These were all people that were actively being recruited and sought after because they wanted to partake in residents, and they knew that a residency program was going to start. And I think that that really shows. So a lot of them are trying to improve on their teaching styles. A lot of them are trying to like help you and educate you. And it really just is amazing because every single attending tries to work with you closely and teach you a lot of the time. Obviously in the emergency department, it can't happen every shift because it can be haywire, but it's great. And then another thing too, I think the reason is the medicine in Chicago is just great. Like the things we see is insane. So at Rush, we're a tertiary care center, and crazy amount of like liver transplant, kidney transplant, like crazy heart failure patients, all these people, really sick people with med lists that you have to like scroll on Epic come to Rush. And then when you go out to the community and you're like, wait, you only have hypertension? Cake. Like it's great. And then, you get the crazy, you go to Sinai, and Sinai is just like mayhem, and you walk into another community place and you're like, wait, there aren't 3 people coding and there aren't 3 gunshot wounds coming in. Like, okay, I can handle this. So I think the aspect of some of the stuff that we get to learn is it just really makes you feel more comfortable with how you actually are going to practice medicine. And it's crazy, like the stuff you get to see, and I just really like it. So yeah.
We do have 2 more residents who just joined us. So Eric and I think Evie's here too. If you guys want to go ahead and introduce yourselves and maybe say a little bit about why you guys wanted to come to Rush.
Sure, I can start. First, I do want to apologize for being a bit late. We were just at our live tissue lab, which I can talk a little bit more about later if you guys are interested. It's really a pretty amazing experience. So why I chose Rush? Like picking a residency and like forming your rank list is all about trying to find like the right fit for you. So I think fit's really the appropriate word. And it's, trying to match up what your goals are. And for me, it was really about finding like an academic center because I want to pursue academic medicine and be like core faculty at an emergency medicine residency. So I wanted a program that's going to help me like build my teaching portfolio. And even in like the first month here, there's so many opportunities for me to already start doing that. Like too many that I had to like already say no to a number of things. And then definitely the patient population that was kind of already addressed. You're in urban Chicago, you see literally everything. And at Rush, everyone has 20 chronic ongoing problems. They have active cancer and they're getting a kidney transplant, on Tuesday. And then, it's a diverse patient population, which is something I was looking forward to, because I think you're going to just be more prepared, no matter what you choose to do in the future, if you've already seen, people from all types of backgrounds. And then thirdly is the people. So I rotated here my M4 year, and it really did feel like a family, really strong sense of community. All the residents were extremely nice, always looking to help me, what they can do for me. And then the faculty, they're always trying to get better too. I think that was talked about. Like they even asked me like, okay, how could I be a better teacher on this shift? What's your feedback for me? So I really, really appreciated that. And I think I've seen that already in the first month. They gave us this first month to kind of get to know each other as residents. So we do a kind of an orientation month when we first get to Chicago, which I know a lot of programs don't do. So we kind of take it easier to start so we can actually get to know our class and become really close. I think that's a huge advantage here. I think those are kind of the three reasons I felt like this was a really good fit for me.
Sorry, my dog is barking at all the sirens, but like Eric said, it's totally about fit, and Rush was completely the best fit for me. So first off, I'm really interested in ultrasound, and Dr. Gottlieb is like a powerhouse. He publishes so much. It's incredible. I don't even know if he sleeps, because how could he possibly find the time to do all that? Second, of course, the culture is really important to me, and I've got 2 kids, so being a family-friendly program was really important to me. And because the attendings are so young, a lot of them have kids, and that makes it really easy to relate to them and like have a good time with them when we're on a shift and talk about kids and stuff in school and what the heck we're going to do about coronavirus and kids going back to school. But that was super important to me. And then the third thing is I went to school here in Chicago, and I love this patient population. I literally went to med school down the street from Rush, and the patient population is awesome. It's so great for our learning because they are so sick, but also just the diversity of people, the diversity of the conditions that you see. It's really excellent for our education. And we were very motivated to stay here in Chicago and love it a lot.
Corey, do you have anything to add, or you want to tell us why you wanted to come back to Rush after residency?
Yeah, so I'm part of the inaugural class. Having that experience was amazing. Being part of a new program, and that we got to really, and we had the program obviously developed for us, but we got to have a lot of say. And then Lauren and Kea, they got to have a lot of say as well, being the second class, and seeing some of the things that we had gone through. And I think we're still, I think we're pretty set at this point, but I think because we went through that culture, I think we still have that culture. And so there's still a lot of ability to make inroads in terms of things that work, things that, don't work as well. And I think even with like coronavirus right now, we've been able to go through things, and make changes as necessary. I want to add something I think has been really important with regard to our program, which is we do have, as mentioned, we have Rush, which is completely crazy in terms of the amount of pathology that we see. I mean, it's incredible. And that's one of the things that I love about being at Rush, but we also have the opportunity to go to other sites that give us a really, really good, well-rounded experience. I mean, it's going to Mount Sinai is a fantastic experience. Going to Copley, Rush Copley and Aurora, which is about an hour outside of Chicago, is just a completely different experience. Very, very community oriented, as is Sinai. And then we have another community site as well that's been excellent. So you know, being at Rush, you have all these services available to you, all these consult services available to you. When you go to these other places, you don't. And you really get a great sense as to what emergency medicine is like in general. And, you know, I think while lots of programs have similar scenarios set up, you know, I can definitely speak to ours being a powerhouse in terms of that.
Definitely, I think I can definitely agree with the sentiment. We have a very diverse pathology of cases, and abdominal pain is never just abdominal pain. Even vaginal bleeding is just never vaginal bleeding. Most times it is, but a lot of times it's not. So I know a lot of you guys had asked about the diversity of the patient population, the pathology of the cases, and I think we're really well situated with our location, with us even being on campus. Cook County is right next door. We share a medical campus with them, as well as the VA Center and UIC, and it never feels of course, you do have a difference of patient populations that Rush serves, but with our community sites, I feel like we have a very well-rounded experience of the types of patients we get to serve, which is amazing. And I think something really unique about our program is that starting intern year, you are thrown into the gauntlets. Interns are mostly staffing our high resource and critical pod. You're working one-on-one with the attending, or sometimes you may have a senior on shift and it's 3 of you. So the resident to faculty ratio is really small, and you get to see the high resource patients. You get to intubate. You may have an intubation on your first shift and someone will walk you through it. You get to do central lines, help run codes, and you get to do trauma your intern year. I know all of us are just like, oh my God, trauma. And I promise you by the time you get to your senior year, you're gonna be like, trauma. But even intern year, you get to rotate at Mount Sinai in the trauma department. And that's something unique about our programs. And not a lot of EM programs have their interns doing a dedicated month of trauma. So just all of those, I think, are really unique. And someone had posted a question about, I recently learned that Rush is a bioterrorism and pandemic response center. You are absolutely right. And that, I think, has given us such a unique experience going forward, right? I mean, Corey was in his last few months of senior year. We were in our last few months of our second year and now our third years. And just being at a pandemic response center, Rush is built for this. After 9/11 happened, the Rush, everything from the architecture to the room placements to where everything is located was built for bioterrorism and like a pandemic response. So you'll see, like, in our lobby, going into the emergency department is a massive pavilion. It has towers going through it, and each tower has the capability to run oxygen, fluids, and electricity. And that entire lobby can turn into a massive recess bay and triage area where in the height of the pandemic that was happening in Chicago, we were able to open up an additional ED within inside, not just our triage tents outside in the ambulance bay, but we had additional ED capacity, surge capacity within that pavilion. So, you know, I think this has really prepared me going forward, because I don't think this pandemic is going to go away anytime soon. So, you know, I think this experience has been fantastic in terms of what it means being at Rush, and the advantage that we have. We're one of the top infectious disease specialists hospitals in the country. We're a CDC designated hospital. So I think all of that just helps us, because we learn from our specialists at Rush, and then when we go out to our community sites, we can apply those concepts in taking care of our patients where we don't have those specialists in-house.
I think to build off of that as well, just with this whole COVID thing, one thing that just blew me away about Rush was the updates we got and how Rush adapted to everything. Like, so Dino Romero is like one of the top wigs in the hospital, and he's an emergency medicine physician. And he kind of like runs the bioterrorism aspect of Rush. And he just turned Rush completely into this epicenter for COVID and handling everything. Like, hospitals were transferring patients to us before like Northwestern even had like a tent up. And it was phenomenal. And it was annoying because I got multiple emails daily, and you already get multiple emails daily, but it was so much better than not getting emails, which I know a lot of other people weren't getting. Their programs weren't communicating with them. And it wasn't even our program director communicating with us. It's the head of the hospitals. We're updating you daily with what was going on. And I think that just shows a lot about what Rush is and what Rush can do. And that was not something I expected. And it, you know, during this whole thing, I never felt unsafe when I was at Rush, and they really just tried to provide for you. And I think that that says a lot. Like they really cared. And so, yeah.
I know someone had posted a question about talking a little bit about the shifts. Sorry, I don't know what happened right there. Talking about how our shifts are run, interns for seniors. So yeah, shifts are all 9 hours. We have an overlap hour in the last hour. So typically you can get out in 8 hours if you're superb, get all of your notes done, you're ready to sign out as soon as your relief team comes out. And that typically does tend to happen, right? So 8 to 9 hours. As an intern in second year, you'll be working about 18 shifts in a 28-day block. And we have all of our blocks are 28 days and 13 blocks per the year. And as I was talking about earlier, the ratio is typically intern to attending. You may have 2 interns and 1 attending, and usually that second intern is an off-service rotator, whether it's peds, IM, anesthesia, et cetera, or it will be an intern, a senior resident, and an attending, and that shift is specifically designed so the senior resident can do some teaching, because soon they will also be an attending. So we have like built out different shift structures, keeping in mind all the different learners and levels of learners we're gonna have. So the ratio is really nice, and I think, you know, when we started intern year, or when I started intern year, it was already established that the interns loved working one-on-one with the attendings. And I think, again, that's a unique feature of our program, which we have retained, because you get a lot of value out of staffing directly with the attending and getting direct feedback from the attending your intern year, which you can use to build your practice in your practice style during second and third year. About a 3-year versus 4-year program, do you guys feel that the program responsibilities feel a bit more accelerated in comparison? Corey, I don't know if you want to add a little bit about that now that you've actually graduated and starting your attending year, what that feels like.
Yeah, sure. You know, so I did another residency before this, a whole other residency. So I'm, you know, I was perfectly happy, of course, with doing a 3-year residency. But you know, I've talked with a lot of people who have done 4-year residencies. We integrate with other residency programs in the city who do 4-year residencies, and you know, I think there's certainly value to doing an extra year. I mean, I don't think we could argue that point, but at the same time, I think I've talked with enough people who say that, you know, I could have been out a little bit sooner. So I think it's probably personal preference. It depends on what you want to, what you plan on doing. Some people don't want to do an extra year. They'd rather do a fellowship right out. Some people just don't want to do the extra year in general. I think it's, again, personal preference. I personally, just in terms of comfort level, I feel very comfortable with, you know, where I'm at in terms of knowledge. I mean, obviously, you have to be a very motivated resident. And I think that we're fortunate in that emergency medicine residents in general, I think, are pretty motivated residents. I mean, certainly at Rush, you know, I don't think we have any lack of you know, sort of like heavy interest in just making sure that you know what you're doing, above and beyond all the things that we're formally taught. So I think in general, you know, again, for me personally, I feel like I was ready. I actually got to do ICU as my very last rotation. And I felt like that was just like the icing on the cake. It just sort of put everything into perspective for me in terms of all the critical care stuff that we do need to know, and just like a really good reminder of you know, being a senior in the ICU is just such a good reminder of all the things that you know, that you start thinking about. Oh my God, I'm going to be responsible for this, you know, in a couple of months. So that was really terrific for me.
And just like kind of going back to the 3 versus 4 year programs, every ER or EM residency program has the same graduation requirements. They have the same amount of ICU rotations they have to do. They all have to deliver the same number of babies and have the same number of intubations and XYZ. So really not much is changing in terms of the curriculum of a 3 year versus 4 year program, whether it's accelerated or not. Obviously, we don't have the experience of the 4 year program and having that additional year, but I feel like 3 year, I mean, we just started our 3rd year, but I feel like we're really on track to be able to learn as much as we can and feel comfortable finishing in 3 years and going on to our 4th year. I know there has been some research and data put out and is showing that there really isn't a difference graduating from a 3 year or 4 year program, and that happy spot of when you feel comfortable that you're ready to become an attending is actually, I think they said, maybe 3 months into 4th year. So I don't think there's an added benefit of it. Again, talking about the programs here in Chicago, there are a handful of 4 year programs. Cook County, Northwestern is a 4 year program. And there's definitely 4 year programs out there, but I think more and more most programs have transitioned to a 3 year program. Another question that was posed earlier was about the cost of living in Chicago. Maybe some of our interns kind of want to answer that, if you've moved from out of town or if you've been a Chicago native, just to kind of get your guys' input on that.
Rush is very accessible, so you can live in a lot of different areas in the city and pay the price depending. So there are people who live like in the Loop area and pay a lot more, but they live in a beautiful place and they have access to like all the fun things in the city. And then there are some people like me who live out in the suburbs, and I live just down 290, and so my commute can be so quick. If it's off hours, I'm there in 15 minutes. So you have a lot of options.
I'm a Chicago native, so I've been born and raised here. But we all kind of live all over. We do have a dedicated webinar for living in Chicago, where we're going to be going into much more detail about the different neighborhoods, who lives where, the ease of access, the typical costs. The cost of living really does depend on which suburb or which area of the city you live in. Do you have an option for getting housing for $1,300 a month? Yes. Do you have the option of paying $3,000 a month and getting a pool and a fitness center in your building? Absolutely yes as well. So there's a wide variety, and it kind of just depends on your own preference. And like Evie said, Rush is super accessible. I don't even know if I'm pronouncing it right, but really easy to get to basically. So there's definitely lots and lots of options. So cost of living is pretty affordable when you're talking about New York City versus San Francisco. Obviously Chicago is one of the more expensive cities, but not as expensive as the other two that I listed. Kind of just going back to some of the questions that were submitted a little earlier before this event, talking about work-life balance, and not just when we're at work, but what about interacting with the rest of the city of Chicago? So we have had a few questions about, do we get to work with other residents? Do we get to work with other programs? So maybe some of us can comment on that before answering some more questions from the chat.
So we definitely get to work with other residents. So one of the places that we do go to is Sinai, and actually Resurrection residents are there. So you kind of get to see them and hang out with them. And then I know that they do trauma with us too there. And then at Cook County, when you guys do trauma there, basically everybody tries to rotate at Cook County so that they can say they did trauma at Cook County. So like Northwestern goes there, obviously County goes there, Res goes there. The DO program from Midwestern, their EM program goes there. There's just like all these people that you just get to hang out with, and like surgery programs go there, so you get to meet surgeons from around the city as well. So it's just kind of cool. I still talk to like everybody that I rotated with all the time. And then also I think it's really cool. So it's not happening right now because of COVID. I think we're all going to be doing it on Zoom, but every year I think we have like 3 annual meetings, like ISEP. So the Illinois College of Emergency Physicians has 2 meetings a year, or 1 meeting, I can't remember. There's 3 meetings though, and all the EM programs from around the Chicago area, including like Christ, come, and you just get to hang out with them, and you guys have like a conference day together. So I think that's kind of cool. You get to see everybody there. You're kind of learning the same things. You can mingle with them. You get to see the people you rotated with and say, hey, like, look at me, I survived trauma. How are you doing? And it's just a lot of fun to kind of see that. And I think another thing too is it's kind of cool. Like last year we had actually this like random thing thrown on by Cook County for like gun violence in the city. So like all the programs just willy-nilly, like one day, I think they like gave us like a 2-month notice or something, just switched everything. And we went to this conference, and we were able to like talk about gun violence in Chicago and have all this. And it was kind of cool to just see the EM people meet up. Also, if you're a lady, there is Women in EM. So there is one of our attendings, actually, Dr. Sarah Hawk, who's super into SIM as well, started a Women in EM in Chicago. So we try to have meetings, like I think it's like quarterly, where we get to meet up and do things. I know Kay and I both went our 4th year of med school together. That's when I met Kaya. We were both like, we just got into Rush High. And it was a lot of fun. Oh, you're on mute, Kaya. Oh, we can't hear her. Oh no.
I said we got to meet the amazing Dr. Chu. Dr. Hawk had somehow arranged to have Dr. Chu come in. I don't know if you guys follow her. She is a EM goddess. Please follow her on Twitter, a huge advocate for women, for social rights, for social justice, gun advocacy, everything. And she's an EM doc. But it was amazing that Dr. Hawk was able to kind of arrange this, and we got to hang out, we got food, we got drinks, we got to talk to her, and it was really, really cool experience and opportunity.
Yeah, so the attendings pay for it, which is really nice, right on our resident salary. So, and then we do try to do it just with Rush Women too. So like we just have like a little track ourselves, especially because kind of with everything going on, it's been harder to get everybody together. So our attendings like talk to us about like, how do you promote yourself and stuff like that. So I think that's really cool too, that like it's like multifaceted with how we get to hang out with the other residents in Chicago. So yeah, it's amazing. I like it.
So we've talked a lot about how our EM program has developed, has changed, how the program in itself is really receptive to change. Maybe we can take a few minutes to kind of talk about some of these changes we've implemented. Maybe I can start first. One of the biggest things was starting from when Corey's class first started to when we came on board, and then our current now 2nd year started, we really wanted to have more community sites available, so we weren't just having all of our ER months at Rush. And from when Corey started until when we started, they had added almost 2 new community sites, and by the time I became a 2nd year, we added 2 more community sites. So I think that expansion was fantastic. And now our interns are able to go to Mount Sinai Emergency Department. They stay at Rush. Then you go to Rush Copley, you go to Rush Oak Park. We are also trying to hopefully get a 3rd site, because someone had mentioned about some hospital closures and how things are getting impacted. And that does mean that you may lose some of your community sites that you rotate on, and that a lot of the programs have to be adaptive to change. So we are now trying to find a new site that we can also rotate at for community. So that was one of the biggest changes that I saw just within a span of a year. And signing on new community sites takes a lot of time. It's not just, hey, we want to rotate here, let's go there. It takes a lot of administrative effort. It takes money, and it takes a lot of just organization and planning to do that. So I thought that was absolutely fantastic. And I think that's worked to our benefit, because you get exposed to all of these community sites early on in your residency. So by the time you get to your 3rd year, you have a better idea of, do you want to do fellowship? Do you want to do a tertiary care academic center? Do you want to go out in the community? Do you want to practice in a hybrid setting, a low resource setting? So kind of intern year, you have that exposure, which I think is fantastic.
There have also been some changes to like the rotations along the way. And I think that sort of goes back to a 3 versus 4-year program, is that our program has done a great job in making every single rotation really valuable, and like you get a lot out of them and you're not wasting a lot of time doing grunt work. For example, I've been on obstetrics and anesthesia this month, and it used to be a longer rotation, and now it's just 2 weeks of each. And that means that I get in there, get everything done, and I'm not wasting time like doing somebody's notes forever. And I think that that's really valuable, that the program, works for that and fights for that. And because the hospital is so, like the hospital administration is so invested in having an emergency program, they make those relationships work within the hospital. And that's just another example of how the program has made changes along the way and is fighting for us as residents to have the best experience.
Yeah, I'll second that too. I was actually just talking with Dr. Dougal, who's one of the attendings here, and he was saying how lucky we are not to have to do just like a general medicine month of just like internal medicine on a basic floor. He was saying how that was the most like useless month of his residency. And, we don't have to do that. We get another month of, ICU or that extra month of trauma. So I think it can be really advantageous.
Also with that, so most 4-year programs, MD programs, they started off as 4-year programs because the first year was actually like an actual intern year. So a lot of those programs are older programs and they just continued with that. So they end up doing a lot more general medicine, especially on the floors. So we don't do that. So that's just like not part of it, but we definitely get our fair share of ICU. So I definitely think that's really good. And I think another thing too is that our ICUs have changed a lot. So initially last year, last year was the first year that we had 3rd years. And so they did like a MICU month, and it was really interesting because the current internal medicine people already had their team set up. So we were basically like an extra team. So that got kind of switched up. So then they were like, we're not getting enough procedures. We're not seeing enough patients. And like literally like a couple months into it, they're like, all right, guys, you're going to do nights. And they're like, loved it because they got to do all the procedures. So you basically stabilized all these ICU players over the night. And then you got to do the lines, you got to do everything. And they loved it. And then we were like, well, should this change too? Like, do we want to do nights? And so we went back to days right now for that. And now we're our own team that's overflow. So with COVID, the ICU has a lot of overflow patients. So I think they're actually managing like 11 ICU players, which is more than the cap for the internal medicine people. And the one resident on it right now is like, I'm doing so much. This is great. And then coming up now, so they're doing this weird cardiovascular surgery ICU, and we're going to be part of the team that actually runs that, and we're going to be our own team with our like attending. And our program director like got in there on the talks with it so that we can get in there, we can get procedures, we can get to do things, we can manage these sick patients, and we get to see it more, which I think will definitely like help us out and help manage us with these patients. Just because I'm sure you're aware, like a lot of times sitting around, especially with surgeons, I feel like they're a little bit more rushed when it comes to actually doing rounds, where if you're with internal med people, you just kind of sit there and you talk a really long time about like, well, they haven't had a bowel movement today. What do you want to give them? And then they argue back and forth for like 10 minutes. And it's like, just load them up with Miralax. That's what we decide every single time. Please, let's move on. So that's always fun. So I think that that's really cool though, that like, there's this whole new ICU playing. Like our program director was already in talks, and he's trying to like get us this really great ICU experience, especially as a first year, like an intern, and a 3rd year to manage it. And so it's this constant changing, and that we're trying to figure this out. And I think one of the really good things about our program being newer is that we don't have these laurels that we need to rest on. Like, well, this is what the program always did. This is what everybody went through. This is what I did when I was in this program. It's more like, hey, no, how are we going to make this better? And that's the mentality that we're carrying through. So I think that's awesome, because I know that a lot of other programs are like, oh, like, well, this sucks, but like, it is what it is because that's how it always has been. but that's not the case here. Like, if you want it changed, bring it up. We'll try to do something. And I think that's kind of awesome.
I see a lot of questions about social EM, global EM, and kind of just what our experiences with that. And I just wanted to kind of break out into that, starting with one of the projects that I'm trying to lead is a emergency department, DEI committee, right? We always have a hospital and a house staff, but what about the emergency department? Emergency department is the access point for so many different patients. So many people come in and work in the emergency department, from social work to environmental services to our pharmacists to diagnostic technicians to attendings, residents, everyone. So one of our biggest initiatives over the past, I would say, 6 months has been to really work on what our focus in our program is when it comes to social justice, equity, diversity, inclusion. And we were able to start a DEI committee just for the emergency departments. And it's not just residents and it's not just attendings. It's nurses, social work, pharmacy, techs. All of us are on this committee. We've put together a curriculum to learn about race and inequity and how it affects our patient population. And the hopes is after going through this curriculum, we can come out with some best practices to see what we can change and how we are taking care of our patients in the emergency departments. And kind of just building off of that, going into social global EM, some of the community outreach we already have in place. One of our residents, Colin, is involved in a program called the Street Medicine Program, which was actually started by some of our last year's fourth year medical students. And basically a few residents, a few attending sign up, and on a weekly basis, we're going out to different shelters in different areas of Chicago that Rush serves to help do dressing changes, provide medications, do blood pressure checks, sugar checks, and kind of just provide some basic care for our patients in the homeless shelters. Rush in itself has a huge community outreach program, and it's called the West Side Initiative. And basically, as a hospital, we have taken the initiative to kind of help alleviate the disparities and healthcare disparities. And I'm not sure if you guys have heard of Dr. David Ansel. He is one of our physicians at Rush. He did his residency at Cook County, and basically he is one of the leaders of this program and just kind of helping us identify whether you're in the loop and then you go two blocks west of Rush, the life expectancy changes 30 years. It drops almost 30 years. So we have invested a lot of resources in helping to get rid of that disparity. So I, at the end of this, I will send you guys, if you guys are more interested about social EM and in our community outreach that Rush is involved in, I can definitely point you more towards that. We within our program have a social and global EM track that some of you have been asking about. It's led by two of our faculty advisors, Dr. Ansari and Dr. Desayanke, who have both had a fellowship training in some sort of social global emergency medicine. And it's all asynchronous. We do some courses, some material that we review on Canvas. We have monthly meetings. We have the opportunity to travel abroad. Some of our residents have gone to Haiti and the Dominican Republic. One of our residents, graduating residents from last year, Dr. Chase Socha, had done an elective out in Hawaii, so that's an opportunity. And hopefully we have another resident who might be doing something even more rural, going to Alaska. So we'll see. Lots of opportunities for social, community, and even rural and wilderness medicine. One of our APDs, Dr. Heinrich, is starting up something with wilderness medicine as well. So again, we do have another webinar that we'll be recording, and we'll have all of these people come on and talk about our social global as well as our fellowships information. So definitely, if you're interested in that, make sure to join. If not, we will send you the recording for that. I'm just looking through to see what other questions there are. Ooh, this one is a good one. Just to get to the personality of the program, what is one aspect of the program each of you is proudest of? So why don't we have Corey start with that, and then we can make our way around.
Thanks. I feel like our program is just really nice. Everybody's nice. everybody treats each other with respect. Everybody is in it really with like a single thought process in mind primarily, which is just to be, good emergency medicine physicians. And this goes to the faculty as well. I mentioned before that our sort of overall level of motivation is very high, I think. And I think when you combine that with people just wanting to treat other people with respect, and thinking about other people and having empathy for other people, I think the mixture is truly excellent.
I can just say I'm kind of just like impressed by our involvement in Rush Hospital. We have Dr. Amoro, who's like the head of like everything basically. Dr. Paul Casey, who's head of quality improvement. We have just like all of our hands in there. We have multiple of our ED physicians, including like our APDs, teach in the medical school. Us as residents, one of our PGY3s was on the HSA board last year. There's just kind of people everywhere that have these roles. And I think that just says a lot. And also just, everything that we've heard from us being on rotations is that people just appreciate our help. So I think it just says something just about the ED family here is that, we play well with others, we work really hard, and we just care about this hospital because we try to get higher up roles in it to try to help it improve. So I think that was also something that I didn't expect when I came here. And it's kind of cool to just see, because we just don't work in the ED and then go home. We're really involved in Rush.
The thing that stands out for me is the focus on wellness. And I think that trickles down to our culture. And because there's such a focus on wellness and making sure everybody's happy, not just at work, but also like having a life outside of work, which is why emergency is the best. But I think that makes the culture so nice at Rush, and you can speak to anybody. It doesn't matter if they're an attending wearing their white coat and you are a med student or a tech or whatever. Like, you can speak to anybody. Anybody will have a conversation with you. It's not all about hierarchy, and that's true with other services too. Like, I think I've rotated at 7 different hospitals while I was in Chicago for medical school, and I've seen a very different culture in different hospitals, but the surgical services at Rush are way more like kind and friendly than they can be at other places. And I think that that's a great place to work, and it certainly makes me happy.
I can go next. Something I'm really proud of is the name we have made for ourselves as our residency program. Rush is a big bougie tertiary care academic center, is very well established, and most residency programs at our hospital have been there for years. So to come in as a new residency and to make a name for ourselves, we're the underdogs. And I am so impressed with how quickly we have been able to show the entire hospital that we are here to stay, we're hard workers, and we are an asset to the hospital and the community. Just, second year you rotate in the PICU. When our first class, Corey's class, rotated in the PICU, some of the feedback we had got was we were hardworking, we were very dedicated, we were compassionate. And then the next year we got invited. I think besides the pediatrics residents, we're the only other residency program that can moonlight in the PICU now. When we started rotating at Mount Sinai, they were super impressed with us, and a lot of the doctors are trying to actually get us to come rotate at Holy Cross with them, which is one of the hospitals they work at. Even at one of our sites that we did end up losing, Community First, a lot of the docs were advocating for our residents to go with them to the hospitals they were going with. So I'm just super proud of how hard our first few classes have worked to make a name for us and to show that we are super dedicated and to build that trust. Before our residency program started in the emergency department, it was staffed by internal medicine residents, anesthesia residents. And, the first year, second year, it was a little hard for for that culture of change to happen where the nurses would go to the ER residents first before going to the attendings. And just through our hard work, that culture of change has come. And it feels so good knowing that now the nurses are able to trust the residents that are in the emergency department because they know we're their own. So I'm super proud of that. One of the things that I was surprised by, someone was asking, was how quickly things can change, and when we bring up a certain issue, how quickly people are able to respond to that. For example, at one point, we were stuck on these old Cisco phones as our resident phones when we were on shift, and everyone in the entire department had gotten brand new spanking iPhones, except the residents, even to the point where environmental services had these brand new spanking iPhones, and we had a meeting with Dr. Ramoro, who's the director of the emergency department. Literally, after the meeting, we brought this up with him. Our chief at that time, Somi, was walking out with him and was just in his ear, we need new phones, we need these phones, we need these phones. And within a week, the entire residency has these brand new spanking iPhones. I think we were able to get 30 phones for us. I was really surprised that when not just our own program directors, but when the director of the emergency department, when the administration, the entire emergency department is really involved in the residents and how adaptive and fast they can make these changes happen. Something I dislike, I hate talking. That's a really tough question because obviously, right, we have so many great things to say about the program. For me, the ICU experience is something that I think our program has struggled with, whether it's our own MICU, whether it's a cardiac ICU. So that was really, interning in my ICU was fantastic. Our PICU experience is fantastic. And something I really disliked about our program was the way our cardiac ICU was structured. We have a combined, it's like a step down / versus a true cardiac ICU. And it just sucked because we were just this additional team. We were really never given any of the sick patients. So I think one of the biggest things our program has identified is that we need better ICU experience, and that goes down to our program leadership getting in there and starting to build this new ICU with a true cardiovascular ICU and getting our residents put in there, with our program leadership telling the MICU teams, hey, no, our ER residents need to have a separate team with their own patient load. They need to do both nights and days and get access to procedures. So that's a change that is happening. And I think that comes because the residents feel so comfortable in talking to our program leadership and bringing these issues up to them. I can go on and on, but I'm going to let someone else talk now. Corey, were you going to say something?
Oh, so I just want to add that the ICU situation, just to dovetail on what you said, that's been an evolving process throughout. We had the opportunity this past year to add on to our ICU experience and do an extra month if we wanted to in the SICU at Sinai. And when you're in the SICU at Sinai, it's trauma / surgical intensive care unit. You're alone and you're there for 24 hours. And it's this past year, it was every Q2 call. It was every 2 days. And then you get a whole bunch of days off. Only a couple of people did that because of other electives that people set up. But what they ended up doing was that went well enough for those 2 months alone that they actually added that on as an additional ICU month for everybody to do. Not as intense as that, but Q3. And I think most people are pretty appreciative of that. So actually, technically, there's an extra ICU month than was originally planned, and they did that because of how much the SICU at Sinai had to offer, and also because I think that the Sinai folks really like us. They like our, as Kaya said, they like our work ethic quite a bit. So I think that just answers a couple of questions. The first one of how fast are we able to change things? I'd say pretty fast. That's been my experience throughout. And of course, the most important things like phones are great, of course, but our education is obviously paramount, and making the changes necessary for our education has been so quick to happen. And then I think again, it also again speaks to how our residents are seen, not just at Rush, because I think we're pretty well respected at Rush at this point, but also at the other places that we rotate at.
So just to kind of finish off here, and I wanted to make sure we answered everyone's questions. There was a question about, I listened that if you do the residency in a 3-year program, we need to do a fellowship to be an attending in the future. Programs are 4 years. Do they need to do that? No. Here, I think this might be someone coming from Spain, but no. 3-year versus 4 years, you do not need to do a fellowship in a specific EM subspecialty to get a job as an attending. It just purely comes down to whether you want to be at a 4-year program or a 3-year program. It doesn't change your salary, doesn't change where you're able to work, what type of community or setting you're able to work in. So I hope that answers your question. And then any opportunities for residents who are interested in EMS. There are a few. We do have certain EMS requirements that we have to do. You have to do a few ambulance rides, you have to get base training and answer some of the EMS calls that come through. And participate in some event medicine opportunities. One of our residents is really interested in EMS and is trying to set up a flight selective, so that might become an option. And Dr. Hondros, he's one of our EMS as well as trauma, works with the military. He does a lot of program initiatives with that, and if that's something you're interested in, he's definitely able to help set you up with something to do either as an elective or selective besides just the requirements we have on a program. And then I think there was one more question that we didn't get to before we just kind of can make our last remarks. Have the hospital closures in Chicago affected your training at all, and do you expect it to in the future? So this is, I'm not sure if everyone has heard, especially for those of you not in Chicago, one of our beloved hospitals closer to the South Side, Mercy Hospital, is going to be shutting down next year. And, that changes a lot of things, right? That means that massive hospital that was serving all of these patients, now those patients have to come somewhere else. And we are going to be seeing those patients at Rush. And does that really change our training? No, it just means that now we're going to get more diverse patients to take care of. But it does put a burden on the system, right? Especially in the middle of a pandemic, you are talking about closing hospitals, and a hospital that has served one of the biggest underserved communities in our city. So yeah, I do anticipate it to change our training and what comes of the patient population, but I think we'll just be able to learn a lot more from that. I don't know if anyone else has any comments to make on that or not.
I just want to add that, I think everybody else would agree with me. I think the nice thing about Rush is if you're interested in something, you can spend time doing that thing. We pretty much have everything. So somebody asked about it. You just answered a question about EMS. We don't have an EMS fellowship, but we have lots of EMS stuff going on, and the person that runs EMS would be thrilled to have somebody doing stuff with them. But I think pretty much everything else we have, literally everything else. We have, going to social EM, we have our toxicology service is also an addiction medicine service. They literally run the inpatient addiction medicine service of the hospital, and they are super busy. And that kind of dovetails into social EM in general. Actually, I went to a social EM conference for Chicago programs with the toxicology / addiction medicine service folks. And when they laid out what we have going on, it was incredible. I mean, compared to most other sites who are more in their infancy with social EM. And those are just a couple of the things. We have a lot of other things going on. We have, I'm interested in behavioral emergencies as well as a niche in EM. And, we have a preferred area within the emergency department. We have an elective that people can take. I'm about to offer a spot to an emergency medicine resident who wants it to be on our behavioral health quality committee, which is filled out with a whole bunch of people from various disciplines around the hospital. We have tons of other things that are open. to pretty much anything you, like I said, anything you want to do. And that's, I mean, I think probably that's kind of an advantage of being in a large academic center that a lot of other academic centers have as well.
And I can speak, like I'm super interested in addiction medicine, and the thing that we're doing in our hospital is like phenomenal for our patients, especially because, as I'm sure you're all aware, working in the emergency department, a lot of people come in with like chronic pain because they have an opiate use disorder, or you have your chronic alcoholics that are coming in. And you know, a lot of physicians previously would view these people as like dead ends and not helpful. Like you can't really do anything, just treat them and kind of send them on their way. And I think, sorry, this is Inigo Montoya. So, and I think that it's changing our culture in the emergency department. And now Christ and UIC are actually reaching out to the two attendings and asking them how they created their program and tried to give them a map of how to do it at theirs, because it's been that beneficial for our people here and population at Rush. And I think that says something. And that is true social medicine, because those people like need it the most. So yeah.
Alrighty, so that kind of wraps up our night tonight. Thank you again for everyone who came out to us, and for everyone who didn't know, Corey actually used to be a psychiatrist in his former life before he went on to become an EM doc. So kind of just to add a little bit about that, like our addiction medicine team is run by 2 EM docs who are EM attendings, board certified in toxicology and addiction. We have a SIM fellowship, we have an ultrasound fellowship, we have our SUS addiction medicine fellowship, we have social and global EM trained faculty, ultrasound trained. We have so many opportunities and so many niches at Rush. And so I just wanted to share some of our future, hopefully I can do this right, share screen. Don't look at all my other stuff that I have on my screen. I hope you guys can see this. You're supposed to be seeing a flyer of the upcoming events that we still have left. Next week, we're going to be talking about the different hospitals we rotate at, sites and skills. We have a whole hour dedicated to our wellness efforts. You're going to get to meet some of our fellows, our fellow trained faculty, and a lot more of our alumni to kind of talk about your new program. Where did everyone go to after their 3 years of residency? So hopefully we'll see some of you guys coming back to join us. And again, thank you guys so much for coming out tonight. Feel free to keep asking us, submitting us questions, and we'll send out this recording as well. But thank you everyone, and have a good night.